So, your patient walks in with a swollen, distended abdomen. It's a classic clinical sign, right? But it can also send your mind racing through dozens of possibilities. I mean, where do you even begin? In this explainer, we're going to build a really clear, logical framework to help you tackle this common challenge, and we're starting right from the basics.
Okay, let's just dive right in. Picture this. A patient is sitting in front of you, their abdomen is clearly swollen. A ton of different diagnoses are probably flying through your head. But where do you actually start? Well, the most effective approach really begins with a single, fundamental question that's going to guide your entire workup. We'll get to what that question is in a bit, but first, we really need to understand the main reason why abdomens swell up with fluid in the first place.
So, all that fluid, it's got a name, ascites. And it's so important to remember that ascites isn't a disease itself. Nope, it's a sign, a really critical sign, that the body's super intricate fluid balancing system has gone completely haywire. Figuring out why this fluid is leaking into the peritoneal cavity, well, that's the key to cracking the case.
So why does it happen? Before we can even think about diagnosing the cause, we have to get a handle on the underlying physiology. And it all comes down to a central and honestly a kind of counterintuitive problem.
And that's the paradox right there. A patient can be carrying liters and liters of extra fluid, but their internal sensors are just screaming that the body is dangerously dry. You know why? It's because the body isn't measuring total fluid. It's measuring what we call effective arterial blood volume, which is basically the amount of fluid that's actually inside the circulatory system doing its job of perfusing the organs. When that drops, the body kicks into full-on survival mode.
This diagram here perfectly maps out the body's complex emergency response. See, when that effective arterial volume drops, it triggers this really powerful hormonal cascade. The two key players you need to know are the sympathetic nervous system and the renin-angiotensin-aldosterone system, or RAS. Both of these systems send the exact same urgent message to the kidneys: hold on to salt and water at all costs. It's a survival mechanism that, in this situation, just backfires and makes all that swelling even worse.
Let's break down that RAS cascade really quick, because it's just so important. It all starts with the kidneys releasing a substance called renin. Renin then kicks off this chain reaction that ultimately produces aldosterone. And aldosterone is the key hormone here. It's the master signal that tells the kidneys, do not let go of sodium and water. This whole vicious cycle is basically the engine driving generalized edema and ascites. Okay, so we know the body is holding on to fluid because it thinks it's dehydrated, but what causes that initial drop in effective blood volume? In most cases of generalized edema, it all boils down to failure in one of three major organ systems. Let's call them the usual suspects.
And this is where your clinical skills really come into play. You can start figuring out the cause right there at the bedside. Each organ system failure leaves its own distinct set of clues. For instance, is your patient getting short of breath just walking to the mailbox? That points toward a cardiac cause. A history of heavy alcohol use and their skin looks yellow? You gotta think liver. What about puffy eyes, especially in the morning? That's a classic sign of a kidney problem.
With heart failure, the problem is simple. It's a failing pump. The ventricle just can't squeeze effectively, and that causes blood to back up in the veins. All that increased venous pressure literally pushes fluid right out of the blood vessels and into the body's tissues, including, you guessed it, the abdomen.
Liver cirrhosis causes a two-pronged problem. First, all the scarring in the liver creates a sort of plumbing backup in the big portal vein that drains the gut. We call that portal hypertension. Second, a sick liver can't make enough of a protein called albumin, which acts like a sponge to keep fluid inside the blood vessels. So, with low albumin, fluid just leaks out way more easily. And finally, the kidneys. They can cause ascites in two main ways. In something called nephrotic syndrome, the kidneys' filters get damaged and they leak tons of protein into the urine, which leads to that same low albumin problem we just saw with liver disease. Or, in chronic renal failure, the kidneys just plain lose their ability to get rid of excess salt and water, period.
So, how does all this build into a practical, step-by-step approach you can actually use? We understand the physiology, we know the main causes, now let's put it all together for that patient sitting in front of you.
And we're back to our first question. The single most important thing to figure out right away is this. Is the edema localized or is it generalized? If it's localized, say just one swollen leg, you're thinking about a local plumbing issue, like a blood clot. But if it's generalized, swelling in the legs, the belly, maybe even around the eyes, that points you directly to a systemic cause, the heart, the liver, or the kidneys.
This single distinction is the key that unlocks the entire differential diagnosis. It's the big fork in the road.
So the crucial point, the big takeaway is this. Before you reach for a fancy scan or a bunch of labs, the answer is often right there in your hands and your ears. A really careful history and a thorough physical exam, guided by your understanding of the physiology we just talked about, will almost always point you toward the right organ system and ultimately the right diagnosis.
So you've put all the pieces together. You know if it's the heart, the liver, or the kidneys. You've diagnosed the cause of the ascites. But honestly, that's just the beginning. The next, and maybe the most important question is, what are you going to do about it? How do you treat it? And that's the challenge that follows every single diagnosis.